Case control studies were developed in the early 1950s as an approach to the problem of investigated risk factors for rare diseases or for diseases with long latency between the exposure and the outcome, for which cohort studies are impractical. Case cohort studies are the most used study design in epidemiology. In case control studies, a sample of individuals that have developed the disease are compared with a healthy group from the same population that produced the cases. Data on previous exposures is collected retrospectively in each group to assess whether the factor was present or not present in the cases and the controls. Here's an example of a case control study. In Brazil, a group of researchers assessed whether the contact with armadillos increased the risk of leprosy. So they had 506 leprosy patients, of whom 68% had touched an armadillo. And there were 594 healthy people, of whom 48 had touched an armadillo. The authors concluded that exposure to an armadillo doubled the risk of acquiring leprosy. And yes, this is a real study and it was published in 2008. A classic example of a case control study was a study that assessed the association between the use of tampons and the presence of toxic shock syndrome. So, in general, toxic shock syndrome was apparently associated with the use of medications for premenstrual syndrome. However, some investigators in 1989 assembled a group of cases with TSS in 6 geographic areas and compared this group with a control of 185 female friends and 187 females in the same telephone code. And they found how many of those have used tampons and how many did not. And they found that tampons use was associated with the development of TSS. This case control study had a strong impact because it led to a Rely brand of tampons being taken off the market the same year. The main steps of a case control study include defining the study question, identifying cases and controls, assessing the exposure, analyzing the data, and interpreting the results. Case control studies are very useful when the diseases are rare. For example, studying risk factors for birth defects or most cancers. In this situation, a cohort study might take many years to conduct, so the big advantage of case control studies is that past exposures and outcomes are measured at the same time. So these studies can be done relatively quickly without the need to wait for a disease to develop or an event to occur over time. A good selection criteria for a case definition should lead to an accurate classification of the disease. The cases are individuals who have the condition of interest. So there are many different accurate and efficient sources that can be used to identify cases, such as surveillance methods or hospital and clinical records, death certificates, admin data sets records, or pharmacy records. The validity of case control studies depend on the selection of appropriate controls. Controls are a sample of the source population where the cases come from, and the purpose is that they will help to estimate the exposure distribution in the source population that produced the cases. There are different types of controls. They might come from the general population. There might be hospital controls that are drawn from surgical, orthopedic, or medical units of the same hospital. Controls might also include friends or relatives of the cases, and the advantages of this is that they might have similar background and exposures. in particular the relatives, might help to control for genetic confounding factors, and so on. How many controls per case? And an equally small number of controls would provide little ability to find associations. So increasing the number of controls up to a ratio of 4 to 1 would be okay and might improve the power of the study. Going beyond this number might not represent much gain in terms of statistical power. Matching of cases to controls might increase comparability between cases and controls. In matching, each case is personally linked to a particular individual control on certain characteristics. It's important that suspected etiological factors or exposure should not be used for matching. One of the disadvantages is the risk of overmatching, which means that we would make cases and controls too similar to each other that can mask the association between the exposure and the outcome. Here's an example of a matched case control study. Cases of invasive cutaneous melanoma diagnosed in Minnesota between 2004 and 7 were assessed from a state cancer registry. Age and sex matched controls were randomly selected from the driver license lists, and self-administered questionnaires and telephone interviews included information about the use of indoor tanning or what type of devices were used, the initiation age, the dose, duration, and the presence of indoor tanning related burns. The odds ratios and 95 confidence interval were adjusted for non-melanoma risk factors, and finally the authors found that frequent indoor tanning increased the risk of melanoma. Exposure status should be measured the same in cases and control, and usually assessment includes interviews, medical records, employment or environmental records, or birth and death certificates, among others. Analysis of case control studies include the calculation of exposure among cases and controls using 2 by 2 tables. When we analyze case control studies, we compare the prevalence of exposure among cases with that among controls. You cannot calculate incidence, but you can calculate odds of exposure and estimate odds ratios with 95 confidence intervals. Why you cannot calculate incidence in case control studies? Let's suppose that we have 100 bladder cancer cases, of whom 60 are smokers, and we select 100 controls, of which 20 are smokers. So we calculate the incidence in brackets among smokers, and it is 75%, and the relative risk would be 2.25. But what happens if we increase the number of controls? Now let's suppose that we select 600 controls and 20% are smokers. Now it appears that the incidence in brackets among smokers is 33% and the relative risk is 4.3. But the only difference is that we have increased the number of controls. Therefore, you cannot calculate incidence in case control studies. Because controls are a sample of the population that produced the cases, you often don't know the size of the total population, and therefore you cannot calculate the cumulative incidence or the incidence rate of a disease, or calculate the measures of association using the methods that we have learned so far. Instead, you get a number called an odds. Information from 2 by 2 tables can help to calculate the odds ratio, which is also called the cross product ratio. And basically, the odds ratio is the ratio between the odds of exposure among the cases divided by the odds of exposure among the controls. Taking the data from our previous example about exposure to smoking and the development of lung cancer, we can see that the odds ratios are not influenced by the size of the control groups. So in this case, we get equally an odds ratio of 6.0 despite the differences in the number of controls in the two groups. Here's an example of an analysis of a case control study of spontaneous abortion and prior induced abortion. In this case, the cases were women that had an spontaneous abortion compared to those who did not, and the exposure of interest was the presence of a prior induced abortion or not. We can calculate the cross product of these cells, and then we can conclude that with an odds ratio of 1.3, that women with a history of induced abortion had a 30% increased risk of having an spontaneous abortion compared to women who never had an induced abortion. Another way to interpret this data is that the odds of prior induced abortion is 1.3 higher given an spontaneous abortion compared to non-spontaneous abortion. Case control studies are less expensive and time consuming. They're very efficient to evaluate rare conditions or conditions with long latency and induction periods. They can also evaluate many risk factors for the same disease. Case control studies are inefficient for rare exposures. They are vulnerable to bias and might have poor information on exposure because of the retrospective nature of the study. And they might difficult inferences about temporal relationships between exposure and disease. The Newcastle Ottawa scale for case control studies is a good alternative for critical appraisal of these studies. And basically, they look at domains such as selection of the cases and controls, comparability between the two of them, and the assessment of exposure. How you choose between control and case control studies. Let's suppose that we want to know what is the association between physical inactivity and heart disease. We can use a cohort study design in which we start comparing individuals that are inactive versus those that are active, and then look over time for assessment of the incidence of heart disease between the two groups. Or you can do a case control study, and then you will start with people with heart disease, which are the cases, compare them with a group of controls, and then look back in time and assess their exposure status and assess how many of those were active or inactive in the two groups between the cases and the controls. With the cohort study, we will start with the exposure and calculate the relative risk. With the case control study, we will start with the outcome and then we'll calculate the odds ratio. In general, cohort studies will be good for rare exposure and common diseases, compared to case control, which will be good for rare diseases and common exposures. Cohort studies focus on one exposure, which might cause multiple diseases, and case controls will focus on numerous factors which might influence the development of one disease. Cohort studies are expensive and time consuming, and case control studies are relatively cheap and quick. The relative risk needs the incidence of the disease and is used in prospective cross-sectional and clinical trials, and it's useful for demonstrating temporality and the relationship between exposure and outcome. The odds ratio incidence is not used for the calculation. It's reported in retrospective and cross-sectional studies. Is a good estimate of the relative risk in case of low frequency of diseases. This is the end of our session number 5. And now please remember to complete the trivia, participate in the weekly forum, and do the short critique of an article. And of course, you can post anytime your questions in the question and answers forum for week 5. I'll see you soon.